From Microbe TV, this is TWiP, This Week in Parasitism, episode 156, recorded on August 7th, 2018. I'm Vincent Racaniello, and joining me today here in a very sultry New York City, Dickson Despommier.
Hello, Vincent.
You do not disagree with the sultriness.
It's wilting temperatures out there.
And joining us from a remote location, Daniel Griffin.
Hello, everybody.
Hello there, Daniel.
How have you been, Daniel? Are you well?
I am well. I've been having a great time. It's been a really enjoyable summer. It's been busy, which is something I enjoy.
Yes.
Have you done any traveling?
No distant travel. I've got a trip coming up, I guess a week from Saturday. So headed up to, I think I'm headed to Canada for a week, but I never know until after the fact.
You mean as you pass the border? Oh, I'm in Canada.
Yeah. No, and I've been seeing a lot of fascinating cases, which I enjoy, and lots of sailing for myself and the kids.
Right.
I feel like my wife has not been sailing as much as she should, but otherwise everybody else is doing, really enjoying the summer. My wife, I think our listeners might find this interesting. And one of the things that we recently took on, me and my wife, is we have a puppy we're rearing to be a canine companion, to be basically a service dog. And that is, like so many things, more time consuming than one might realize.
Wow.
Right.
What kind of a dog is it?
It's a mix of lab and retriever, but it looks like the cutest black lab you've ever seen in your life.
Oh, my goodness. Those are very friendly dogs.
Oh, the friendliest, nicest dog you may have ever met.
How long do you have to train it before you give it away?
You train the puppies for 18 months, and then the puppies go off to school for 4 to 6 months, and only 40% of them actually make it as service dogs.
Mm-hmm.
Wow.
What happens
to
the others?
60%? Yes.
It's interesting. If the dog can't make it as one of their service dogs, they have other assistance programs that the dog might qualify for.
Like pet therapy or something like that, you mean?
The main focus of the organization is for people with physical disabilities, but then there are people with other types of disabilities that the dog might then be able to go to an organization. And then there's apparently an 8-year waiting list for people that want these dogs as pets or companions.
Wow.
That's
amazing. Now, Daniel, you run the risk of really liking this dog and not wanting to give it away, right? After 18 months, that's a long time.
Foster parents.
No. So I've already figured this one out, because I actually really do like this dog. And her name is Hattie, and Hattie is incredibly cute. So the same approach that I'm taking to parenting, I really love my children too. And I find that if my children or the puppy succeed, that I may never see them again. The puppy might go off, live with someone else. My children might move to Europe or California. Exactly. But if they fail, then they could live in my basement, and I can always be around those I love.
So you undertrain, is that it? That's very interesting. You should mention that, because as I'm sure also people that have been listening to this podcast for a while realize that I got my training to begin with Dr. Harold Brown. And Dr. Harold Brown was responsible for establishing medical schools in various places. And one of them was in Bali. And he came and told everybody, and he didn't tell them, of course, but he told everybody else, that he planned the medical school to be low tech, so that the doctors who trained there would not be able to find work anywhere else except there, because they didn't know how to do certain things that other people did. Like, for instance, I guess they didn't have any fancy machines. Mm-hmm. Right. In those days, a fancy machine was an X-ray machine. So I'm not sure what he meant by that, but they purposely dumbed down the medical education to a point which prevented them from emigrating to another place after they finished their training. And it was, I had mixed emotions about that. I don't know how you feel about it, but
I like your seg. I was once told, always tell people when you're joking because some people might not get it. So I am joking about wanting my puppies and children to fail. I want them to succeed.
Perhaps like succeeding at the limit of being able to migrate away.
But I do love my children, my puppy, and my wife, and I would like them all to stay close, but succeed at the same time. But no, the thing that you bring up, Dickson, is an interesting issue in a lot of parts of the world where they say there are more medically trained physicians out of Malawi in England than there are that stay in Malawi. So what a lot of countries have realized is instead of creating a situation like that where you train somebody at a very high level and then they may decide to go elsewhere, is they create another tier of medical training, and sometimes they call them medical officers. And I know Nepal had a program like this when I was there. A lot of countries in Africa have programs like this where they train the physicians in, I wouldn't call it dumbed down, but what I'll rephrase it as what they're training them is the skills they need to work in the settings that exist in those countries.
Yeah, that's right.
Which in many ways are, there are no CAT scans, there are no advanced diagnostics. Yeah. So it's interesting. Some of these people are trained with a slightly different focus, and some of them, the physical exam skills are amazing. Right. And so their ability to detect a pneumonia on a lung exam is up there with most of our ability to read that off a chest X-ray report. So it's a different type of training. It's a focus on the needs of the context and where they'll work, and it's a realistic decision to realize that we don't want to invest all this money in a country in training people that are just going to leave. The goal to training the medical professionals in a lot of these countries is to build up the human resources there.
Here. Speaking of which.
let's do our case.
Yes, let's
last
do that
episode,
case.
Daniel.
Okay. Now, I described this as another challenging one. This was the case of a 60-year-old man with a poorly defined immunodeficiency, which I described as characterized by low immunoglobulin levels, low T cells, and something that this gentleman was being treated with chronic immunoglobulin therapy, intravenous IG therapy. And they were admitted with a 1-year history of chronic diarrhea. They had an upper endoscopy, which had visualized inflammation of the duodenum, crypt hyperplasia, and diffuse ulceration. There was a colonoscopy, so a lower endoscopy, and the colon was visualized as having a granular appearance. And we commented there was a loss of haustral folds. Biopsies were done. Things were also sent off for culture. And then we gave a little more context. This gentleman also had a poorly understood interstitial lung disease. He'd been unable to work and did not have any toxic habits that he told us about. This gentleman was born in Ecuador, but moved to the U.S. when he was in his early 40s, and he was living in the outer borough of Staten Island. No fever, his blood pressure was low, his heart rate was accelerated above 100. He was breathing a little bit quickly in the high teens. And his exam was remarkable for this being a gentleman who looked frail, but not acutely toxic. He had a normal white blood cell count, but there was a shift to the left with an increase in the neutrophils and particularly the eosinophils. The albumin was low. There was a respiratory pathogen panel positive for rhinovirus. The CMV was greater than 4,000, and that was a measurement of the virus. Gentleman was started on ivermectin, which was followed by a white blood cell rise, and at that point, the person was put on broad-spectrum antibiotics.
All right, well, despite it being August, we have a number of guesses, which is great. First is from Wink, Dear TWiP. Professors, tough case. I do not know the diagnosis, but that will not stop me from taking a wild guess. My gambit is Chagas disease. I know that this 60-plus man with low globulins and low lymphocytes does not have a typical case of American trypanosomiasis, but some associations were intriguing. 1, there is transmission in Ecuador and the parasite travels well. 2, I found a report indicating that even if you do not get megacolon, the colon can lengthen and cause loss of haustra? 3, the text says that immune-compromised individuals can present with acute symptoms and diarrhea and diarrhea can be an acute manifestation of Chagas disease. And the text is with a capital T. 4, the lung findings may be caused by a separate pathogen from the colon, perhaps CMV. Here's hoping, wink in Atlanta. Dickson.
Yes, sir. Alexander writes, "Hello, Al. With all the talk on molecular testing, I get reminded of a story of a talk where the scientist was studying the genetics of one phytoplankton species and had the wrong species on the PowerPoint. My next question that I have is, generally, how expensive is it to run a nucleic acid amplification test?" So I had a lot of fun reading on this case, and I ended up getting distracted a lot. I ended up looking into Cystoisospora belli, Cryptosporidium parvum, and Dientamoeba fragilis. I think that it might be Cystoisospora belli after reading that it was identifiable in a biopsy and that it causes peripheral eosinophilia. To jump on the weather recording bandwagon, the nearest National Ocean Service station in Westport, Washington, was reading 58 Fahrenheit this afternoon and a water temperature of 57 Fahrenheit just before high tide. I wish we had something like that here, but we don't. He has the benefit of the Humboldt current, however, so that's why it's kind of cool out there.
All right. Kevin writes, weather Chicago, 80-degree days, 60-degree nights. Our 60-year-old Ecuador-born man who has lived in the USA for 20 years has a chronic immunodeficiency with a superimposed year-long diarrhea resulting in disabling, frailty, and overall poor health. He presumably has some type of humoral immunodeficiency, most likely primary, i.e. not acquired secondarily like AIDS, CLL, myeloma, etc., for which he is receiving IVIG. His intestinal workup shows involvement of the small and large bowel with a variety of histopathological and radiological findings. Many of the facts in this case may be essential clues, red herrings, or just plain insignificant incidental findings. The parasitic devil is in the details. I will confine this discussion to the topic of infectious colitis in the context of primary humoral immunodeficiency, leaving aside a proper differential diagnosis that would include non-pathogenic etiologies such as malignancies, inflammatory conditions, etc. The more than 60 primary immunodeficiencies have been described. The most common is IgA deficiency. With the exception of Giardia infection, IgA deficiency is usually not associated with opportunistic infection and usually not treated with IVIG. The second most common is combined variable immunodeficiency, CVID, which is probably what this patient had or some similar variant. Pathogens that commonly occur, though not specifically intestinal, in CVID, strep pneumo, H. flu, pneumocystis, Giardia, Cryptosporidium. Loss of haustral folds is a classic sign of colitis, and I'll run down a list of potential etiological candidates. 1, not consistent with our case, Shigella, Salmonella, Campylobacter, Shiga toxin-producing E. coli or STEC, Clostridium difficile, tuberculous colitis, histoplasmosis, actinomycosis, CMV herpes. 2, potential candidates for us, various protozoans, Cryptosporidium, Cystoisospora and Cyclospora, Balantidium coli. Rarely, pneumocystis can cause extraintestinal disease. Other bad guys, Giardia lamblia, E. histolytica, and a variety of nematodes. Time will not permit going through the pros and cons of the many pathogens mentioned above. Though Cryptosporidium is the most statistically likely candidate to be causing this disease, especially in view of chronic diarrhea symptoms, I would like to focus a moment on reactivation Chagas disease as a likely culprit or co-conspirator in this case. T. cruzi is endemic in Ecuador and can remain dormant in a human host for many years. Reactivation during leukemia treatment or post-organ transplant is usually myocarditis or encephalomeningitis, but the GI tract can also be involved. Chagas intestinal disease is usually associated with constipation, but fast transit in a dilated small intestine is due to bacterial overgrowth, can result in chronic diarrhea, malabsorption, and steatorrhea. I'm going to submit a dual diagnosis of co-infection with cryptosporidium and reactivation Chagas disease. Treatment for crypto, nitazoxanide. Treatment for Chagas, nifurtimox. Red herring disposal. The finding of leukocytosis following ivermectin empiric treatment is concerning for the possible development of DRESS syndrome, a drug reaction, see the reference. The CMV viral load of 4,000 is intermediate and not really a smoking gun for disease. The threshold in one study was 10,000 copies for renal transplant patients. As for the rhinovirus positivity, like the fighter pilot who faces an instrument panel with every light blinking and alarming, shut the whole thing off and use your mind. Thanking the entire TWiP staff for chronic mental stimulation.
Goodness gracious.
And I think I should probably tell people what DRESS syndrome means. So
I would like to know.
Okay, so that is a syndrome where people wear dresses. No, it is a
I beg your pardon.
Drug reaction with eosinophilia and systemic symptoms. So it's really a hypersensitivity reaction to certain medications.
Okay. This guy is really thorough. He gives a lot of references after.
Always does, Dickson. Always does.
It's remarkable.
He has a paper here from 2018, ivermectin-induced drug reaction with eosinophilia and systemic symptoms. DRESS is a potentially life-threatening adverse drug reaction with an estimated mortality rate of up to 10%. They report a case of DRESS caused by ivermectin, which, to our knowledge, has not been reported previously. This is July 2018. It's like last month, dudes.
That may get into our next version of our text. Because ivermectin is used a lot.
Next one is from Hannah.
Yeah.
Dear TWiP hosts, I'm usually reluctant to guess when I don't think I'll get it right. But I figure it's good to challenge and embarrass myself once in a while and let other clueless listeners know that they're not alone. Let me just say that I think if you don't push yourself, you don't grow, right?
This is true.
Because if you're
my brothers used to say that when we would go skiing. If you say, "Oh, I didn't fall," they're like, "Well, you weren't pushing yourself."
Yeah, skiing, you have to fall because right. Otherwise, of course, people don't like to fall because they think they're going to break something.
Sometimes they do.
Yeah. All right, back to Hannah. Unsure of where to start, I tried Googling and searching your textbook for the gut-related keywords in the case description. This didn't give me the quick answer I was hoping for, but it did point me toward two possibilities, Entamoeba histolytica and cryptosporidium. Crypto can cause crypt hyperplasia in the small intestine, chronic diarrhea, and weight loss. But I'm not sure about the other described symptoms. E. histolytica can also cause diarrhea and weight loss, but from what I've been reading, it colonizes the colon rather than the small intestine. It could, however, be responsible for the granular appearance to cecal mucosa. According to Parasitic Diseases, 6th edition, Cystoisospora can also cause protracted diarrhea and weight loss in immunocompromised patients, but I don't know if it can cause the described gut pathology. The closest match that I can find through Googling is actually to ulcerative colitis. That would explain the ulceration, loss of haustral folds, and granular mucosa. Since this is TWiP, I'd be surprised if there wasn't a parasite involved somehow, but could it be that this patient has more than one thing going on? I expect I'm barking up the wrong tree here, but it's been fun, and I look forward to hearing what it actually was. Cheers, Hannah.
That was a good letter. Tony writes, Dear friends, I am Tony from Spain. Now the weather report. Today in Zaragoza, Spain, we are expected to be between 35 and 20 degrees C. I think you meant 40. I think that's a mistake. Mostly a sunny day.
It's a very broad range.
That's a very broad range, but we are in the middle of a hot wave, or heat wave. With respect to the case study for TWiP 155, this is my guess. Some findings strongly suggest amybiasis caused by Entamoeba histolytica, a very highly prevalent parasite in developing countries, including Ecuador. The ulcers are consistent with Entamoeba histolytica, but these tend to be localized in the large intestine rather than in the small intestine. Also, eosinophilia is not common in protozoal infections in general, and in amybiasis in particular. Eosinophilia should suggest some worm infection. Since this patient is immunocompromised, the white blood cell count must be interpreted with caution. Assuming this is a real eosinophilia, we must consider a possible worm infection. Schistosomiasis by Schistosoma mansoni and again Strongyloides stercoralis can be two possibilities. Schistosoma mansoni typically affects the large intestine, and ulcers, granuloma, and pseudopolyps are visible with image techniques. Eggs are easily seen in fecal concentration samples. In the case of strongyloides, the small intestine it is its preferred niche, and ulcers can also be visualized in endoscopy procedures. In both cases, amoebiasis and strongyloidiasis, diagnosis can be very difficult, and several additional samples may be necessary. I once read an article where 12 consecutive fecal samples were necessary to detect S. stercoralis larvae. Serology may be helpful in the case of amoebiasis, but in this very case, where the patient was on chronic IG therapy, the interpretation may be difficult. I think the negative predictive value is much more valuable in our case than that of the positive predictive value. Trophozoites and cysts can be visible in fecal samples, but the chronic condition surely guarantees that the concentration of both forms must be very low. So in this case, a chronic biopsy can be helpful to detect the metabolically active forms, trophozoites, inside the colonic wall. If confirmed, I would look for additional cryptic undetected infections within the closed contacts. So finally, my guess is our patient has a chronic infection with Entamoeba histolytica and may be a co-infection with Strongyloides stercoralis, or less likely, Schistosoma mansoni. P.S. I listened with great interest to the last episode about dracunculiasis in otters. That reminded me of the case of Dracunculus medinensis in Africa, where recently dogs have been implicated as reservoirs for this nematode. I have some doubts, and I wanted to share them with you. One, some researchers suggest that this is not a recent phenomenon, and that spillover must have occurred long ago. Only when we are in the verge of elimination of this situation has been detected, and some argue this is because of high level of surveillance. So do you think it is a recent phenomenon? Two, is the life cycle similar to that of humans? Do the dogs develop itching, painful blisters and then force them to search for water sources to alleviate their symptoms? 3. How do we manage this infection in dogs? We must keep them tied to ropes in order to prevent them from going to water points? 4. How this new reservoir threatens the goal for eradication campaigns. As always, thank you very much and best regards. That was a good letter.
Do you have any concerns about Dracunculus and dogs?
I don't. I do not.
So this does not threaten global eradication?
No, I don't think it does, because most of the transmission that we're really concerned about occurs when people go to step wells to obtain their water supply to take them back to the villages. And that's when we break that cycle, the dogs are not going to be a problem for that one, I don't think.
All right. And then do you have to treat this in dogs? Do they get itching, painful blisters?
It depends on if it's a pet or if it's a semi-feral dog, because there's a ton of those out there too. So you can't really go around the countryside treating every dog that you encounter. I'll give you the example that I can think of best in my travels to Bhutan. It was a great trip, but I can't believe the number of feral dogs that there were. I mean, they were feral, but they were still hanging around the streets during the daytime. At night, they would bark like crazy and keep everybody up. And they were really mangy, and they were poorly cared for because no one took ownership. And there must have been a lot of toxic coriasis, for instance, there. And I didn't see anything. Well, I wasn't looking for that this condition of dracunculiasis there, but I do know that the world is a different place when you start to travel to less developed countries, and I'm sure Daniel has the same experience in his travels throughout Central and South America and Africa as well. To see so many dogs in so many places that are uncared for, it'd be impossible to actually address this on a community basis, I think, unless you were in the business of rounding up the dogs and actually killing them, which they've done in some situations in order to eliminate Echinococcus granulosus, particularly on Cyprus. But that's an unusual situation. And the same was true for the Echinococcus situation in Iceland. But I think for Dracunculus, it would be difficult.
Yeah, I would say it's interesting, too. Like, not only do we keep track of guinea worm in humans, but they also keep track of it in dogs, and it's going down, too. So, right. Sort of good for them too. we're getting rid of it. Yeah.
Exactly.
Just we have these poor otters.
Interesting. Yeah.
All right, back to our case.
Right.
We had 5 guesses.
Yes, we did.
You know, the theme, I would say, is some people are suspecting more than one infection.
Yeah, because they're hedging their bets. I think that's a hedge on the bet. I think you have to rely on the laboratory diagnosis at this point, and you have to then say, well, okay, you did everything that you should, and Daniel has not given us the big reveal on that yet, but I'm sure he will. And once the lab diagnosis comes back, you have a better idea of what to do next.
All right. So, Daniel.
Yeah. So I think I'll say a few things. One is, as I mentioned, this is a challenging case. This isn't one of those where you just say, I know what that is. And then, you're waiting on this biopsy result to give you some direction. And I always try to pick cases that I felt had some kind of clues. And I always worry about like the elevator talk. Like you could always say like, oh yeah, I saw this 60-year-old gentleman from Ecuador with chronic diarrhea and immune deficiency and eosinophilia. What do you think it could be? And then boom, I think people like if you put the case together that way, they can do quite well with the guessing. So putting it together that way, does that help you, Dickson, with a guess?
Not yet. No, because I'm not prone to guess until I see the lab diagnosis. So unless you're going to stick me out in the jungle someplace where there is no lab and this is all I've got to go on, then I think giving prophylactic ivermectin was a good thought based on the eosinophilia. And the white cell count did go up afterwards. That is to say, it did have some either placebo effect or some direct effect on the infections at hand. But I'm still, I hope that there's a clinic somewhere there that send a sample to and get back an answer.
So since this hospitalization occurred right there across the street from our central recording studio.
It's right here.
I would say that we have every right to expect a better diagnosis.
So there were some amazing things that happened, and
did they happen here?
and the biopsy result came back showing cystoisospora.
There you go.
Wow, look at that.
That was my secret guess, but I didn't want to say. No, I'm serious. It's true because it's the only protozoan infection that I've learned about recently that actually does cause eosinophilia. So, and certainly schistosoma couldn't be the cause of this. It's just too long a term for that. And strongyloides could smolder that long. It could have been strongyloides, but we've had so many of them, I didn't think Daniel would throw another one at us. Mm-hmm. And then certainly not histolytica, because histolytica never invades the small intestine.
So 2 people guessed that.
They did.
Interesting.
One of the interesting things that I don't think I sort of threw in just because I thought it was maybe, not as helpful was that they had done during this workup, they had done a gastrointestinal PCR panel. And although there are a number of pathogens that are on that panel, the parasites would be Cryptosporidium, Cyclospora, Entamoeba histolytica, Giardia lamblia. So those were negative. The interesting thing is cystoisospora is not on that PCR panel.
It's not that common.
Yeah, so it's sort of an interesting, and I think the other thing that we should mention is that when you're doing a lot of your stool tests, if you don't know to do stool microscopy with either a specific fluorescent technique or an acid fast staining, you often can't see this on a normal ova and parasite exam.
Right.
So what did you see that said it was cystoisospora, Daniel?
So this was actually a biopsy. So when they did the colonic biopsy, the histological section on H&E staining showed the cystoisospora species. And then the patient was started on Bactrim, and to maybe this will be a nice tip to everyone else. But you know what? The blood cultures also grew Klebsiella. So there was some compromise, at least the theory was compromise of the intestinal or colonic barrier. And so the person did have more than one thing going on. They had our protozoan, our parasitic infections, but they also had bacteremia with Klebsiella. So they were treated for the cystoisospora, but they were also treated for a gram-negative rod bacteremia.
Right. And what do you attribute the rise in white cell count from treatment with ivermectin to?
So the interesting thing that we often see, we tend to think like, oh, this person is sick. Their white count is high because they're sick. A lot of times with a gram-negative bacteremia, the white count will be low, and as you start to treat and improve, it'll rise. So it's interesting, and that the ivermectin may not have been the cause of the rising white count.
So the broad-spectrum antibiotic was the real reason why the white cell count returned to normal. Then
I think that's probably true.
Okay, great.
So this gentleman's symptoms were all consistent with cystoisospora. Is that correct?
Yeah, exactly.
So
not only were they consistent, but the proof of the pudding, as we say, is after the patient was treated, they removed. They improved. They removed.
They removed their parasites. What was the treatment? Just remind us.
Okay, so they initially were started on the IV Bactrim for the cystoisospora, and they were then treated with antibiotics based on the Klebsiella sensitivities. But I think we should talk a little bit. Why don't we hit life cycle and then talk about treatment options? Yeah. So do you want to talk about life cycle, Dickson? Should we do that one?
I'm not as sure about it as you are, so I'm serious about that. This is a relatively newcomer for me, so why don't you continue your discourse?
It's sort of a simple life cycle, actually, I should say. I mean, it's really, the fecal oral contamination, and then again, someone else is going to have it come out fecally orally, and then you're going to have contaminated water or food, and so it's a very simple life cycle. Outside, there's a very interesting life cycle occurring intraintestinal. Is sort of an asexual and a sexual stage that occurs in the intestines, which I think we actually updated the figure in our latest text. So people
this
can
is
look
an
forward
apicomplexa? This is an
It is. It's an apicomplexa.
Okay. So it is distantly related to Cryptosporidium, and it has a resistant stage that actually survives the environment and then allows it to be transmitted from person to person by fecal oral contamination.
So that's how this gentleman acquired it?
Yeah.
Where do you think he acquired it?
That's a great question.
That is a great question.
How long can this thing smolder like this?
I mean, you think he got it in Ecuador?
He wouldn't have needed to. This is something that we see patients acquire in the New York area without any even travel history. So, the Ecuador was an interesting part of the history, but you don't necessarily need to leave our locale to acquire this. It's the immunocompromised. I think this is probably more ubiquitous in our environment than we realize. But with a normal, robust immune system, most of us never have any symptoms, never are aware that we've been exposed to this, and it's the immunocompromised people that are really the sentinel.
Right.
Do you ever see this in AIDS patients, Daniel?
So that's where I've mostly seen it in AIDS patients with usually pretty low CD4 counts, less than 50.
Wow.
And a lot of what helps is restoring the immune system. So we're seeing a lot less of this, I should say, now that we're doing a better job with treatment regimens for HIV.
And how did the patient turn out?
The patient did great, actually. They improved. They got better. They were able to get discharged from the hospital. And I should say, as far as treatment options, if you can restore the immune system, that's ideal. And that's always been our approach that we've gotten from the HIV population. But trimethoprim sulfa, right? So your Bactrim is an agent that is preferred. But there's also some other options such as nitazoxamide. Some people use fluoroquinolone such as Cipro, though they say that might be inferior. This patient actually was treated with Bactrim, and then later, this was because they were improving and the Klebsiella was sensitive to fluoroquinolones, they ended up on Levaquin, which is also a fluoroquinolone.
So this is very interesting. A few weeks ago, I received an email from an NIH virology program officer, and he told me about a meeting that is taking place in September. It's open to the public. It's called Chronic Enteric Infections in Transplant Recipients. And the description goes, the successful management of transplant in primary immunodeficient patients has led to the increasing occurrence of chronic gastroenteritis in these subjects. Unlike acute gastroenteritis, chronic infections can lead to months or years of illness with varying severity, often resulting in decreased quality of life or even death. So this is a workshop to explore what's going on.
Wow.
in this area.
Wow.
I wonder how much of it is. Well, the topics include viruses. Well, they actually don't have anything else besides viruses.
That's why they wrote.
That's why you're the target audience.
Well,
Right, but
I can't make it. He wanted to know if I wanted to go and do a TWiP there, but it's an interesting idea, especially in light of today's discussion, right? So these transplant patients will be immunosuppressed. So maybe some of them have cystoisospora.
Maybe.
Belli.
Maybe.
Sono belli.
That's right. A lot of transplant patients also pick up toxoplasma from the transplant, from the organ that they receive. And it was also true during the outbreak of West Nile virus. There was a guy who was actually killed in an automobile accident and had written in his will that his organs were to be donated whenever possible. And about 8 other people caught his West Nile infection from his latent infection that he had. So lots of things to think about when these transplants are very common now, right? Especially among diabetics. Type 1 diabetes gets a lot of play because of the kidney transplant
a lot of kidney transplants. And it is, as an infectious disease specialist, this is becoming a bigger part of our practice, is caring for people who are immunosuppression after organ transplant.
Here you are, you survive a life-threatening illness with a transplant, and you end up succumbing to a common infection that the rest of us. So they should be concerned, of course.
Well, someday we will have organs from pigs.
You think?
That don't have any infections.
Well, I thought you were going to grow them in stem cells and scaffolding that you could
do that
yourself.
That's probably longer term, isn't it?
Maybe. No, it could grow fast.
No, I think
the size of the organ.
Both those are active areas of investigation, and they're trying to create genetically modified pigs that our immune system will be more compatible with, because there's certain, I think it's like DAF and a few of the other immune surface proteins that humans have as part of our system that the pigs do not. And so if you could genetically modify them, sort of humanize them somewhat. So a little sort of scary when you consider the intelligence of these animals that we're using for organ sources. But
they also have to remove the porcine endogenous retroviruses, the PERVs, because
haven't they done that in China already?
They're worried
CRISPR?
about them. Yeah, they've done it here. George Church's lab. We talked about it on TWiP a long time ago.
Yeah, that's right.
And that looked pretty good.
Yep.
They got pigs born without, 30 or 40 endogenous PERVs. But
should we hit a few more of these other comments? People
please.
Brought up Chagas. I don't know if do you have any thoughts on that, Dickson? I thought that was interesting. People brought it up, but
because it is endemic to Ecuador. But I think that it doesn't cause eosinophilia, for one thing, and the other thing is if you're immunocompromised and you have Chagas disease, you're going to die quicker. That's a fulminating infection at that point. So
I don't think it would present this way. The megacolon, right? And it's interesting. We're still not sure. I mean, here we are in 2018, and we're still trying to understand Chagas. But one of the theories that I think is reasonable, that is prevalent, is the idea that a lot of the neurological damage that creates the gastrointestinal manifestations happens during the acute insults.
That's right.
And then there's an evolution that's occurring, not necessarily because of disease activity. So it's usually much more of a chronic presentation in general. Yes. And again, without this person's, not doing well. They've got eosinophilia. They're acute hospitalized. I'm not sure this would fit with Chagas, but I think it was interesting for people to be remembering the epidemiology.
Yeah, that's right. Yeah. You didn't have any heart changes either, so I think that was another thing that you would have expected that at least, right?
Well, that's interesting too. And we've talked about, is it a host issue? Is it a parasite issue? But you tend to see more gastrointestinal manifestations in individuals from Central America and more cardiac manifestations in people from South America.
Right.
And so I think that's an interesting thing too.
Yeah.
And I don't know if any of us really understand why that is the case.
No. And it just so happens that the paper that we're about to discuss is about Chagas disease.
So what about strongyloides and schistosome? And no?
Remotely. Well, strongyloides is certainly a real possibility, but and it, for a moment there, when the effects of ivermectin were discussed, I said, okay, but wait a minute, that's not all there is to this. Because just returning the white blood cell count to normal is not enough. You've got to do more than that. And his symptoms had to go away. And for that to happen, you have to treat the right infection.
Yeah, but they were good guesses. I mean, obviously the team at Columbia was considering this.
Sure. No, I think that's absolutely right. But by process of elimination, no pun intended, you could actually come up with the right diagnosis. And the biopsy was the key. Absolute key.
That was.
Now, if it was strongyloides, you would have seen it there too.
All right. And
one of the guesses was, I think E. histolytica is a possibility, but it doesn't ordinarily infect the small intestine. That's absolutely correct. Right. So you could have eliminated it based on that alone, I think.
That's a good point.
But by the way, there is an eosinophilia associated with E. histolytica, but it's not a circulating eosinophilia. It's a tissue-based eosinophilia.
Yes.
And it's called an hemiboma, and that results in an accumulation of eosinophils at the site of infection and in the large intestine, and it can often result in something that resembles a tumor, and it can slow down the gut transit time. And if you have strongyloides superimposed upon the E. histolytica infection, you can actually have a hyperinfection cycle going on at the same time. And I've actually heard about one case where that was the issue. So it could very well have been two kinds of infections, and ivermectin would have had something to say about it. And Klebsiella would have been consistent with a strongyloides infection as well, because you do get a bacteremia with strongyloides infections that are hyperinfectious. So all good points.
What do we do? Kevin is getting chronic mental stimulation from TWiP. What do we do about that?
I think we should make it more acute. Let's make it every day rather than just once every 2 weeks.
All right, we had 5 guesses. Here we go. Random number between 1 and 5. 5.
Give us the draft.
Number 5, Tony from Spain.
Really? Tony from Spain gets the book? Excellent.
And now, Tony, please send me, I will need your address and a telephone, since it's international.
Is he in Zaragoza? Is that what?
Zaragoza.
I've actually stayed there. It's a lovely city.
Send it to TWiP@microbe.tv, Tony. Your address and telephone. We need telephone for international shipments.
Right.
All right. Congrats.
Wait a minute. Why don't you ask him whether he wants the English version or the Spanish version?
Do you have print versions of the?
We do.
Tony, do you want? I can't say it in Spanish. Can you say it in Spanish?
Daniel can say this.
Do you want the English?
¿Quiere la edición en español o en inglés?
Por favor.
And then you'll have to get one and sign it, both of you. These have to be signed.
Absolutely.
Which will further delay, but that's fine.
I'm sure he'll appreciate the delay.
What a treasure that would be.
Yeah. But meanwhile, he can download the PDF Spanish version just to see.
Of course, I'm sure he has.
What he's going to get.
All right. Now, step 2 or part 2 of TWiP.
Part 2, yes.
Is a paper.
Yeah.
Which Daniel selected.
Yes.
It's in Scientific Reports.
It's a good one, too.
Which is open access. It's the open access offering by Nature. Most of the journals are closed, but they have to put one up to say, we do open access too. Imaging the development of chronic Chagas disease after oral transmission by Luis Francisco, Yaya Wardana, Langston, Taylor, and Kelly. And these individuals hail from the London School of Hygiene and Tropical Medicine.
Yep.
Are you familiar with this?
I not only am familiar with it, I've actually had many a tankard of alcoholic beverage served on the premises. I had a good friend who worked there for a long time. His name was David Denham, and we used to meet in England every now and then.
Did he wear denim?
No, he didn't. That's interesting to actually note that. He was a wonderful parasitologist that worked there and worked on filariasis, among other things, and trichinella as well. And they have their own pub.
Nice.
Right down in the cellar of that.
Why don't we open a pub and do our podcast right in the pub?
Yeah, we could do that. And I think this was established by Sir Patrick Manson, if I'm not mistaken. the original London School of Hygiene and Tropical
You and
Medicine.
I could do it in front of the audience.
We could do it.
Daniel could come in via Skype.
He could sail over. No, I think Daniel should sail over in his new boat. I think that should happen.
So, Daniel, what attracted you to this paper?
There are several things. I mean, one is I love the images, right? It's great.
Yeah,
it's wonderful to see, and I know we'll have to be sort of describing these for our listeners. But one was the images. I thought that was really interesting. The other is, as was brought up a little bit earlier, we still don't really understand Chagas after all these years, and it is a tremendously important parasite, tremendously important pathogen. And I also like the fact that it discusses oral transmission, which is interesting because I'm sure I've brought this up in the past. Is a lot of times when you tell a patient, or I should say, I've had the experience a lot of times where I tell a patient that they have Chagas disease. And in many parts of the world, telling someone they have Chagas disease is suggesting that they're from a place of poverty and they live in a home with a thatched, not a modern concrete home. And what has happened by, I think, recognize oral transmission, you could introduce this into the dialogue and say, it may have been something you acquired orally, and you can help remove some of the stigma that used to come with it. But the other is actually, there seems to, at least there's been an observation that people that acquire Chagas orally, at least human beings that acquire Chagas orally, they tend to get sicker. There tends to be higher mortality. And so not only do we need to better understand Chagas, but this is a growing route of transmission with more serious consequences. And it's very important that we understand this as well.
Dickson, it says here that consumption of triatamines by wild mammals is a key part of the T. cruzi transmission cycle.
That's correct.
Can you explain that?
I can. Well, let's say, for instance, you're a feral dog, or you're even a peridomestic dog living in let's say, the rural areas of Brazil, and you see this very large, ugly bug sitting on your back, puncturing your hide, basically, and sucking your blood. As a dog, what's your instinct?
Yeah, you're going to bite it.
You're going to bite it and chew it up and swallow it and say, the hell with you. That facilitates the transmission of this infection, apparently. So that's very significant because that maintains this infection in the wildlife and in the peridomestic wildlife right next to where you live. So the people wouldn't do that, but animals certainly would do that.
So when they eat the bug, when they acquire the bloodstream trypomastigotes, right?
Well, the first thing that occurs during this infection is that the parasites invade the tissues right where they were deposited. Let's say they're not injected by the bugs, but they're deposited, so that you get a cellulitis basically, and it's called a chagoma. It's usually unilateral in the eye if you rub it into your mucous membranes, but in the oral cavity, I don't know what it looks like there, and we're about to find out because that's the crux of this article. Along the beaches of wonderful places like Ipanema and in Rio, along the beach of Casa. No, that's not the right one. Come on, what's the famous beach there?
Where? In
Rio. Not Ipanema. It's
no idea.
Yeah, it begins with C. Copacabana. The Copacabana. This is where the elite come to play.
Yeah.
And they play, paddleball on the beach, and they wear their little string bikinis and stuff, and they drink fluids that are served to them by vendors that come by. And one of those drinks is derived from sugar cane. And it's crushed sugar cane that's then flavored with some fruit juices and things of this sort. But you can trap the reduvid bugs in this cutting of sugar cane. And when you crush it up, of course, you release the organisms, and then they get into the fruit juices. And then the next thing you know, these, as Daniel would say, these people do not come from the barrio. They come from the privileged sections of Brazil, and they end up catching this infection, and they can't understand how that happened. And so they've actually worked out this epidemiology of oral transmission.
Interesting.
Yeah, but Vincent, I liked your questions because I think maybe it helps, and this paper helps us with the fact that normally when we describe, and even we do this in our textbook, when we normally describe the life cycle of Trypanosoma cruzi, so American trypanosomiasis, we have what Dickson described, is where the reduvid bug actually defecates the infective form onto our skin, and then either it's rubbed into a mucous membrane, and let's say the eye, for instance, and that's your classic chagoma, the swelling of this area around the eye, or they get rubbed into the bite wound because it's itchy, and so they're living, let's say, on the walls or the thatched roof, and then they come down, and the feces ends up in our eyeball or in the wound. It gets rubbed in, and so initially you have the metacyclic trypomastigote as the infective stage. Right. But the other potentially infecting stage is the blood trypomastigote. And one of the things that our paper is going to look at is which type of form put as an oral gavage, is going to actually be infective, and which one put in the oral cavity, so buccal, sort of the inside of the cheek, which form is going to be infective. And we're going to learn that for gastric lavage, so being put in the stomach, the blood trypomastigote is not infective, but the metacyclic is. But if you put them in the oral cavity, both forms. So if you go and you chew up one of these bugs, which is bigger than your thumb, all the ones, the trypomastigote forms that are in the blood, as well as the normal metacyclic trypomastigote, the normally infected form, is also going to be able to infect in the mouse model.
Right. So, but if you just put the trypomastigotes, either blood or metacyclic, in the mouth, you can infect.
Exactly.
But in the stomach, only the MTs work.
The MTs. That's it.
Exactly.
Which has something to do with stomach acid and being invading, and they talk about this a bit later.
Yes.
And when you inject the intraperitoneal, either's fine.
Either's fine by injection.
Or intravenous. That's right.
All right. So that's the result. That's it. Now, an important part of this is imaging of the mice to track the infection.
Very much so.
So, Daniel, do you have a handle on this imaging? Because Dickson and I were trying to sort this out. They actually inject a luminous substance into the mice of some luciferase.
They're using firefly luciferase. I don't know if you use this, Vincent, in any of your research, but we use it quite a bit. And in
luciferase or luciferin?
Luciferase, the enzyme.
So what is it?
Wait a minute, Dickson. Maybe they put luciferin.
What is it acting on? I think it's luciferin.
Let's see. Let's look at the methods. Let's go to the videotape.
Let's go to the videotape.
Exactly.
So T. cruzi expressing redshifted firefly luciferase were used in all experiments. And then, of course, they inject the substrate.
So these are
luciferin.
These are genetically altered trypanosomes.
There you go.
I love that. Okay, now we got the story.
Now, see, when you were working, you couldn't do this.
Nope.
Now, if you were working today, you would be using genetically modified T. spiralis.
I would be. And people in Europe wouldn't eat it because it's GMOs.
But then you could
pretty funny, Dickson.
See if they glow.
You could see if they glow. That's right. And this is the interesting thing, is that the animal rights people love this kind of study because you don't have to kill the animal to see where the parasites are. You just shine a light through them.
Which is pretty
These are living animals. These animals are all alive.
They could do this. They wanted to do this to see where the parasites end up in the animal.
Yeah, that's right.
See if there's any difference by giving it orally versus IP, right?
Right.
Then what did they find?
Okay, so I think hopefully our listeners got these. So you've got these mice that have been injected with these genetically modified parasites, and they have this enzyme that we're getting from our fireflies. And we have Boy Scouts that go out and collect them. Actually, I don't know if you guys have ever, I joke about that, but Steve Goff, right, we were talking about this one time. And that's what actually used to happen in the old days. They had Boy Scouts collecting fireflies.
Yeah, sure.
Now we've all kinds of modern ways of, genetically producing this stuff. But, and then you're going to inject the substrate and you're going to anesthetize these mice, and then you're going to do this bioluminescent imaging. Which is really pretty cool. So they start off with they'll call figure 1, right, which makes sense for their first figure. And there's pictures of these mice basically laying there anesthetized, and the more red is the higher intensity, and then the lower intensity gets to a blue, and then if there's no intensity, the areas are just white background. And so they image them whether or not they've been exposed to blood trypomastogotes or the metacyclic trypomastogotes, and they're going to image them at 14, 56, 84, 112, so different time points, and then whether they inject these intraperitoneal, whether they're exposed through an intragastric exposure, or whether this is a buccal exposure. And the comment that we made, so we'll start off with the intraperitoneal injection. Initially, right up front, the mice turn bright red, and it's actually pretty diffuse, which I thought was really impressive.
Yes,
it's everywhere. Yeah.
And then as you go along, it seems to sort of diminish and localize in certain areas. The intragastric, the mice stay white when they do the blood trypomastogotes, and you only see blue activity with the metacyclic. So orally does not, in this experiment, seem to be like a most efficacious way of exposing.
Although the blue is diffuse as well. It's everywhere.
Exactly.
Yeah.
That's right.
And then again, it also, sort of diminished by 112. But then the oral, right? And this is what we're really talking about. When they put the metacyclic trypomastogotes orally, the mice turns as red as it can get.
Yep.
When they do metacyclic trip. And, you get some red areas, a lot of yellow, which is sort of right below when they do the blood trypomastogotes. And then as time goes by, there's a little bit of a diminishment and localization.
What does this oral mean? They just put it in their mouth?
They do.
And
right against the side of the cheek.
And they could swallow it, right?
They could.
But some of it remains there and it begins to infect right in the buccal cavity, right?
That's right.
Okay.
That is right.
Did you tell them, don't swallow right away?
I think they have to train them. No.
Don't swallow that pill.
Exactly.
Huh. Okay. So the tropism is not really altered by this route of inoculation.
No, these metacyclic trips are programmed to attack any cell they encounter first, whereas the trypomastogote stage in the bloodstream, they're probably destined for nervous tissue of some sort.
So what we've learned so far is that the oral is not very efficient, as Daniel has said, but eventually you can infect pretty much the same tissues as if you inject it. The chronic distributions are comparable, broadly comparable.
Indeed.
Now, Daniel, they're interested in cardiac pathology. Why do they look at this?
Well, the two areas that I think we worry about the most are the intestinal tract and the heart. And as we mentioned when people were giving us guesses before, is we see a lot of cardiac manifestations, a lot of heart damage from Chagas in South America. And it's actually probably the most common cause of heart failure in South America is the Chagas impact on the heart. The other manifestation, which is a little more common in Central America versus South America, is damage to the colon as well as the esophagus. And you can end up with this megacolon or megaesophagus.
Mm-hmm.
I've heard cardiologists exclaim that Chagas disease is the most common cause of cardiomyopathy in the world.
And that probably is true. From a worldwide, that's probably true.
Yeah.
So they wanted to see if it made a difference, cardiac pathology after oral versus injection.
Right. And what did they show? He said quizzically.
Exactly. They say there's really, no significant difference in severity between the oral and the needle injected cohort. So, they didn't really find that there was going to be a big difference here. So I thought that was sort of interesting. I think they anticipated finding a more striking difference here.
This is true for mice. Now, we're not sure about humans.
Is there some anecdotal evidence that oral inoculation leads to more serious heart problems?
Well, so I think they mentioned that in the paper too, and that's been what's been described in these, I should say, outbreaks, because it's interesting. You'll have a sugarcane beverage, as Dickson was describing, and then there unfortunately will be some of these reduvic bugs in there get mashed up, and you'll have, let's say, 80, 100 people get sick at the same time. And then, at least based upon the assessment, it seems like a higher percent of people are getting more acutely ill, and maybe even a higher mortality in these contexts than we think is occurring in other exposures. But I'll throw this in as my perception. There may be a big inoculum, right? If we're saying, normally you've got, you're rubbing a little bit of feces in your eyeball, a little bit in an open wound, as opposed to, you're swashing this stuff around in your mouth that may be just teeming with blood as well as metacyclic trypomastogotes.
They say here that insect-derived metacyclics express a surface glycoprotein called GP82 that binds gastric mucin and facilitates invasion of the gastric mucosa.
That's very interesting.
Isn't that interesting?
It is, because that's not a normal route. Or maybe we didn't know it was a normal route, but maybe it is a normal route.
Right.
Maybe little kids, you can imagine a small child that's being bitten by a reduvid bug, rubbing the itchy part of wherever that is, even if it's not around the eye or something, and then putting their hand in their mouth and sucking on their thumbs or whatever they do when they're small infants. They've got organisms on their hands, and that goes right down through the oral cavity and could invade the stomach.
This is interesting. The blood trypomastogotes are not transmissible in the stomach. They do not produce GP82 because they are not adapted for low pH environments like the stomach.
Bingo.
So in the bug, the reduvido, they're in the gut of the reduvido.
They're in various places in the gut as they develop.
Is the gut low pH of that bug?
That's a good question.
Might be, because that's what you're saying here.
I don't know much about the reduvid bug gastrointestinal physiology.
All right.
I do know that it's ligand dependent. So if the reduvid bug sucks up human blood with trypomastogotes in it, they stick to the foregut first, and then they transform as a result of that into the promastogote stage, and then after that into the metacyclic trypomastogote, as I recall. And those are sequential. They detach as soon as their new surface proteins occur as they go through their developmental stages, and later on down the gut tract they stick to that part of the gut tract, and then they develop further, and finally they end up in the anus.
Now listen to this. I always like the last sentence or two of a paper.
Go for it.
They say the mucosal transmission does not result in long-term host-parasite interaction dynamics that are more or less pathogenic than non-mucosal. This has potential implications for management of chronic Chagas disease patients and the design of oral vaccines. What are the implications for the treatment of patients if you know, Daniel, that eating versus being injected doesn't matter?
Is that a meaningless statement, do you think?
It might be.
I'm not sure.
Faint words?
Either way, you're going to treat the disease the same way, right?
Well, there aren't too many options here. There are not too many options, unfortunately.
What are the options?
There are just two drugs as far as benzimidazole and nifurtimox.
And I'm not sure. I think we may have talked about this. I'm not sure how much of a difference they make, which is a little discouraging. There was a paper that came out 1 or 2 years ago, I believe it was New England Journal, where what they did is they said, well, let's take the people who have latent Chagas. So these are people who were infected with Chagas. They haven't shown issues yet, but they're at the highest risk, let's say, for cardiac manifestation. We're going to treat them because that'll be give us the lowest number needed to treat to show how effective our drugs are. And the trials really did not show an impact. Yeah. And so that's a little frustrating because these drugs are not easily tolerated for the extended treatment.
Exactly.
And so we're better off, I think, if we can come up with a vaccine strategy where we can prevent people from getting the infection. And as I was suggesting, a lot of the damage may occur up front, particularly the gastrointestinal manifestations, maybe even some degree or significant degree of the cardiac fibrosis. So I think what I'll take away from the last sentence is, yes, it would be great to have a T. cruzi vaccine.
It would be interesting also to know whether or not if you circumvented the stomach with metacyclic trypanosomes and injected them directly into the small intestine, would they be infectious at that level? Because if they weren't, then I can imagine a drink which is concocted to contain the receptor portion of the molecule that's the trypanosome 82. What was the designation for that protein again?
GP82.
Right, or it's a glycoprotein 82. You could block its transmission simply by peppering the drink with the ligand and blocking at that level. Then you could still have your drink and not get infected.
Yeah, maybe it wouldn't taste good.
It'd be sweeter. It's a glycoprotein. Come on.
Peppered it.
Oh, it peppered. I see your point.
You see, that's a little joke, but
I guess I didn't mean to say peppered.
I'm not good at jokes.
That was a good joke, actually. I liked it. It was fine.
All right, now part 3 of TWiP is a hero.
We do have a...
It can't be yourself, Dickson.
I would never do that anyway. Even if I was, but I'm not. Today's hero harkens back to the days of discovering the life cycle and the pathogenicity of a now well-known infection, hookworm. And our hero is none other than Angelo Dubini, MD, born in 1813 and died in 1902. It says here that Dubini is credited with describing the adult stage of Encylostoma duodenale, which he later named. He discovered the worm while conducting an autopsy on a young woman. Bill Hartz, another worker who's got a disease named after him, bilharzia, working in Egypt, made the connection between heavy hookworm infection and severe anemia. So that's the clinical connection. Some years later, Dubini was called in to help identify the cause of an epidemic of severe anemia and death among workers engaged in digging the 15-kilometer St. Gothard's Tunnel that eventually connected Italy with Switzerland. Dubini identified hookworm as the cause of the illness. He published his combined findings in 1843. This seminal paper was to inspire studies into the cause of southern laziness, a disease that gripped the Southland following the American Civil War and led to the establishment of the United States Public Health Service. So Dubini is a hero in having made the observation that, yes, you can have a clinical correlation between heavy hookworm infection, anemia, and in some cases death. And indeed, that's exactly what they were finding in the American Southwest following the end of the Civil War. So that's our hero for today.
Dubini.
Dubini.
Thank you, Dickson.
You're welcome.
That was part 3.
That's part 3.
And now part 4.
We're heading to part 4.
Is a new case study. Although I don't know if Daniel has any more left.
You think he's out of patience? He's becoming impatient.
All right.
I don't think so.
I hope people like this one.
This man is very resourceful.
I enjoyed this. This is a patient that I just was asked to see recently. So are we ready?
We're ready.
We are. I'm on the edge of my chair.
While on the infectious disease consultant service. So as working as an infectious disease consultant on Long Island during July, we're asked to see a woman in her late 70s who is being admitted for fever, confusion, and diarrhea. Now, she has a past medical history significant for cirrhosis, chronic reflux, esophagitis, fatty liver disease, hypertension, and ITP. This is an idiopathic issue with low platelets. And she presents with 2 to 3 days of abdominal pain, nausea, and vomiting. She gives this story that about a week prior, she was at a family party and reports that she drank 2 large glasses of Scotch.
That's what I would do.
She then had diarrhea, which she said was watery. It was non-bloody. It was about 4 to 5 times per day. There was then there was some vomiting about 2 to 3 times per day, and no blood in the vomiting. She then went on to develop a fever of 103 degrees. She had a headache, and then after this, she just felt like she didn't want to eat. And she, according to the son, and had not eaten for 4 to 5 days.
Wow.
So here's this woman, right? So she's got a fever, she's got diarrhea, she's not feeling well, and she ends up being hospitalized. She says no one else is sick. No one who went to this this picnic, family party, had been sick, and they were all outside in sort of the backyard of a person's home in Suffolk County, Long Island. I'm going to give you a little more history. We mentioned the past medical history. And going back a little, she says that back in 2005, she had this episode where she had turned yellow when she had returned to visit Nepal. She hadn't had any surgeries that she tells us about, so she isn't allergic to anything, doesn't describe any diseases running in the family. Now, for her ITP, she's chronically on prednisone, 40 milligrams a day. She also takes metoprolol, amlodipine, and a PPI, so pantoprazole. That's for her esophagitis. So that's an acid suppressive medicine, I will describe it as. We get a little social history. She's retired from working in a retail shop. Her family actually still has a successful retail shop on New Road in Kathmandu. She lives in Suffolk County in a private home, so that's Eastern Long Island. She's never been a smoker. Apparently, she occasionally drinks Scotch. A little bit of her travel and geographic history. She was born in West Bengal, India. And I should describe that. That's the northeastern part of India, if that helps people.
Near Assam.
Exactly, right near Assam. She then moved to Kathmandu, Nepal, when she was a teenager. And she lived there actually until she was in her 50s. And as mentioned, she lived in the nice part of Kathmandu. Her family had a successful shop on New Road in Kathmandu. And she moved to Long Island about 25 years ago. But she returns to Nepal periodically. And her last trip was November, December, where she was there for about 2 months. When she went back, she stayed in Kathmandu. She also, we get a little more history earlier in the month, so a few weeks ago. She had done, I thought it was pretty impressive for a woman in her 70s, but she did a 3-day camping trip with the family at one of the state parks in Eastern Long Island.
I thought you were going to say she went to Annapurna.
No. So 3-day camping trip with big family. Everybody was there, and they stayed in tents. And it doesn't describe any pet exposure.
How about water? What did they drink for water?
So they brought water with them.
They brought water with them. She did not drink from a stream.
Not that she tells us about, but that's a good question.
Was she in Nepal when the earthquake hit? She was not there, but she had been before and after, but not during the time of the earthquake. But no, it's a good, interesting.
Her exam, when we first see her, she isn't running a fever, but I think I mentioned she had a temperature up to 103 before she came in. She's breathing normally, but she had an increased heart rate. Her sclera are white; they're not yellow. She does have some dry mucous membrane, so she looks like a little dehydrated, but the lungs are clear. Her heart rate is normal, but there is a murmur. When we examine her belly, she has a small liver that's small in size on percussion. We're not able to appreciate an enlarged spleen. It does seem like there might be a little bit of a fluid wave, and the belly is somewhat distended with increased bowel sounds. Her white count is elevated at 38,000 with 54 neutrophils, 27 lymphs, 12 monos, and no eosinophils. So we've got our eosinopenia. Her hematocrit is a little bit decreased at 30. Her platelets are low in the 20s. We do a CAT scan of the belly, and we're seeing a cirrhotic liver. We're seeing gastric and perisplenic varices and some acidic fluids. The lactate is elevated. Her sodium is a little bit low. Her bilirubin is a little increased, 3.9. There's a slight increase in the AST into the 90s. And this can be the little last clue we get. When they look when they're doing the peripheral smear, they notice that there are some intracellular ring forms, and the report is read as less than 4% intracellular ring forms.
You said,
Interesting, right?
Something going on in her liver, huh, Dickson?
Benedict Cumberbatch was here. He would, I'm sure, do a good Sherlock on this one. I just watched one of his reruns the other night and was absolutely astounded the way he handles dialogue. He's an amazing actor. But this would even stump old Sherlock, I think.
So I want people to think it through, and I actually think I'm gonna say you can get this from this case, and there are certain clues that I want people to sort of think about. So we're seeing ring form. So what sort of, and we're giving you the hint that we're dealing with parasites here. So which parasites give you intracellular ring forms?
There are several.
Really?
So think about that. And then I also want you to think about the percentage.
Right.
So the percentage is also
less than 4%.
Less than 4%.
Still.
I think the Scotch is a ringer, huh? A red herring, sorry.
Well, we know that it's not...
what kind of Scotch did you drink?
Yeah, right. Single malt or blend?
Yes. I bet it's a blend. She sounds like she's a blend person.
Okay.
I don't know.
Not many people like...
Fascinating. This is a very interesting case. This is a fascinating case.
Yeah. And it's nice. This is one that we just recently got consulted on.
Cirrhotic liver. That's very interesting.
Kathmandu.
Isn't there other enzymes that you can measure to confirm that cirrhotic observation?
So I think I mentioned the AST. So AST, ALT are two of the liver enzymes. We also sometimes look at albumin, right? And that
right. How's
give
that?
us so her albumin is low at 2.4, which is less than we would hope for a normal. Exactly. But the total protein is actually 7.7, so that's actually in the normal range. But her albumin is low.
Got it. But spleen normal. Interesting.
No, spleen is not enlarged, so normal size spleen.
Normal size liver.
Liver small and cirrhotic.
It's hard to the touch, is what you're saying.
So on exam, it's hard to feel it, right? Because it's so small, it's below. But when you percuss, the percussion lets you know it's smaller, and then our CAT scan shows that it's small and cirrhotic.
Dear.
And so people let us know what you're thinking. What would be the next test you would do? And you get this call at 7 p.m. Hey, we're seeing intracellular ring forms on this smear.
Right.
Less than 4%. What do you do therapeutically right then? So that's also I'm very curious to see what people think.
Outstanding case.
Let's read a couple of emails here. I'm going to rearrange some of these here. All right, the first one is from Chris. Good morning to my 3 favorite parasitologists. And yes, Vincent, after 148 episodes, I think you can consider yourself a parasitologist. Here in central New Jersey, it's a sunny but cold day at 37 degrees without a cloud in the sky.
That's Fahrenheit, not Celsius.
It's got to be. This must be an old email.
Yes.
I am emailing you today for a multitude of reasons. The first one being that I really enjoyed the discussion of the paper I sent you a few weeks ago on raccoon roundworm. So I've come back to suggest another ecological parasitological paper. I think this paper would be cool for the podcast because it's a cool cross between basic parasitology, applied science, and anthropocentric environmental impacts. Also, it wants to use parasites as a tool, which I know Dickson is a fan of. Paper's a little old, but still very relevant, and I think it's cool to discuss some of the older influential papers.
I agree.
Secondly, I've just been accepted to grad school at Stony Brook University in Long Island, where I will be studying the parasites of Alaskan fish. So if I catch Giardia while sampling in Alaska, I know which infectious dock I'm going to visit. Additionally, I want to thank you and all the members of your other podcasts for helping me stay involved in science and the countless advice you have given me to and the others in my position. So a question I've been wondering for a while is because there are so many infectious diseases caused by using human feces as fertilizer, has there been a foundation devoted to just making fertilizer? I feel like instead of investing millions in researching complicated prevention methods, the money could be spent to make large composting fertilizer facilities in countries that use feces as fertilizer and then distribute this fertilizer to farmers. The initial cost might be a bit, but once it's set up, it would just involve collecting leaves, grass clipping, food waste, etc., then composting it and distributing it. Am I oversimplifying the problem with this approach? After listening to your podcast, it seems like there are so many diseases that wouldn't exist if people could just avoid feces, and by removing the benefits of feces, people would probably be fine with not using human feces. I can't imagine people enjoying using it as fertilizer in the first place. I would love to hear your take on this idea. Dickson, what do you think?
Big answer. Tell him to call me. There's a lot to talk about in that one. There is.
Is it a good idea to make fertilizer?
It's a good idea to use something else besides fertilizer. And you know how I feel about that. Indoor farming doesn't actually use what we would call classical fertilizer. And so therefore you could avoid it altogether by simply farming indoors.
That's right. But, there are a lot of farmers that are going to continue their practice.
No question about that.
And we've talked about this quite a bit on TWiP.
Yeah, we have
already. And
that's right.
Well, if you want to talk to Dickson, send TWiP at microbe.tv. I'll forward the email to him.
Yep.
Lastly, I'm currently catching up on TWiP, and I was listening to episode, it's got to be 472, not 72. And Ellen's Pick of the Week, the NOAA iPhone app, reminded me of something I think you and your listeners would enjoy. New Jersey has an invasive species strike team, which is a group that is devoted to monitoring and removing invasive species in the state. The reason the NOAA app reminded me of this is because the invasive species strike team has a very similar app that allows people to document and report invasive species found in the state. This app allows the team to effectively control and monitor invasives with the help of citizen science. Furthermore, the app has really detailed descriptions, picture, and control plans for each species. I thought this would be a cool pick for your listeners due to the fact that you all commonly talk about invasive species ecology and its education. It gives links to the website and the app. Cool. That's very cool.
Yep.
So the thing is, I hope the app helps you identify it as invasive, because otherwise most people might not know, right?
Most might not know.
And they would step on something that's not an invasive species, and that wouldn't be good, right?
Yeah, we're mostly interested in invasive tick species and mosquito species, so you step on one of those, they'll bite you.
So the paper that he suggests is called Environmental Parasitology, What Can Parasites Tell Us About Human Impacts on the Environment by K.D. Lafferty. It's from 1997.
Yeah.
Parasitology Today.
Yep.
Okay.
Yep.
All right. Let's read. Daniel, can you take Steve's?
Steve Rice. And we got a little YouTube. I don't know if anyone watched that, but hi, host. No sooner do I hear of a barnacle parasite speeding crabs to a gruesome death on TWiP than this or another barnacle parasite turns up on Jordan Klepper's comedy show, Sterilizing Male Crabs. Thought you might like. And he gives us the YouTube link there.
All right.
Laurel writes, Dear TWiP crew, I must begin by saying that I'm not a parasitologist. I'm a poet. I found your podcast several months ago and have been hooked ever since. TWiP is so accessible, and I've had a great time exploring your archives. For the past several years, I've been writing parasite poetry. My debut poetry collection, Red Mother, New York Q Books, 2018, is a love story told from the perspective of a parasite. This series of short poems explores the intimacy, desire, and devotion we all experience by following the sometimes tender, often distressing relationship that emerges between a parasite and its host. Far from romanticizing either role, Red Mother takes readers on a tour of their own innards, exposing the hooks and claws of all involved. You should know that Red Mother is not about any one parasite. Instead, the book is an exploration of the intimacy of parasitism by utilizing characteristics from multiple parasites. Following the parasite's life cycle, the book blurs the line between science and poetic license to create a fantastical romp, not for the squeamish. If you'd like, I'd be very happy to send you a complimentary copy of my book, along with a few others for you to give your weekly winners. Just let me know where to send them. Red Mother is also available on Amazon, Barnes & Noble, Ingram, and other online booksellers. And then she gives a a website for details. Thank you for providing such an interesting podcast. While I'm not from a science background, TWiP has let me experience a community that I'm very grateful for. The best. Laurel.
All right, Laurel, I'll send you an address.
Laurel,
We'd love to give away some of your books.
We would. In your honor, I've actually written 3 poems.
3 what? Poems?
3 poems, and I'll just read one to show you how terrible I am at this. There was once a larva from Kent whose hind end was curiously bent. While approaching its host, it gave up the ghost, and instead of infecting, it went.
It's funny. But that's like a limerick, right?
It is a limerick. And then I'll finish with my other one. I have to read this one. A guinea worm's thin, not too thick, and they cause us much pain. We get sick. The blisters they make harbor larvae. Think quick. Grab the head. Wrap it up on a stick.
Daniel is not smiling.
I noticed. I noticed that he wasn't smiling.
But I'm lost in thought because I was just thinking. I always wonder, like, how do we help people remember all the things about parasites?
Yeah. No, this
songs and poems are good memory things.
This could help.
There you go. Well, yes, I think that's cool.
Do you want to hear the last one?
All right, go ahead.
A female worm dubbed Trichinella harbors twins whose names rhyme with chlorella. The girl's name's Miss Ella, and the boy's name is Fella, while thousands more live in nurse cellas.
Did you just write those recently?
I did. I wrote them in inspiration from this email that we received, because I read that before in earlier TWiPs. And how unusual for a person to grab onto a podcast simply for the content so that they could construct interesting relationship-based poetry around parasitism. Yeah. I love it. We'd love to receive a copy of your book.
Yeah, well, I will get the address.
Trust me, we're not squeamish.
Listen, Dickson, this is the cool thing about putting things out there.
Yeah.
If you hold everything within yourself, you're not going to ever inspire or teach anyone.
No question.
And here we are using modern technology, i.e. the internet, to distribute stuff, and we can influence people.
Clearly,
as you've seen on all of our podcasts.
An overlap between science and art.
We can talk about that on Friday.
Yeah, I know.
You can find TWiP at Apple Podcasts, microbe.tv/TWiP. Send your case guesses and emails to TWiP at microbe.tv. If you like what we do, consider supporting us. You can go to microbe.tv/contribute. We have a number of ways, including Patreon, where you could say, give us $1 a month.
Or more.
Dickson Despommier can be found at Racaniello.org. Do you want me not to give that out?
No, that's fine.
It's the old one?
That's fine.
It's the old one, but we're revising it.
We are remastering it.
We're remastering it, but that'll be up in a couple of weeks probably.
Yeah, it will be, I think.
Racaniello.org and thelivingriver.org.
Right.
Thank you, Dickson.
You're welcome.
Daniel Griffin is at Columbia University Irving Medical Center, parasiteswithoutborders.com. Thank you, Daniel.
A pleasure as always.
I'm Vincent Racaniello. You can find me at virology.ws. Thanks to Ronald Jenkins for his music and ASM for their support of TWiP. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon. Another TWiP
is parasitic.